It is my pleasure to welcome our presenter. Dr. Joseph B. Stanford, MD, MSPH, is a family physician and vice chair for research in the Department of Family and Preventive Medicine at the University of Utah. His research and clinical practice are focused on fertility and its relationship to birth and child health and development. Joseph, the stage is yours.
Thank you. Let's see, share screen. And here we go. All right, brings us off. All right. Thank you for the opportunity to talk today, and I hope to I should have a few minutes at the end for some questions. And if there are pressing questions that we go through, I'll try to look at the chat, and somebody can also speak up if missing that. Today, I want to talk about the incidence, prevalence, and resolution of infertility in the general population, outline some of the main underlying causes, and talk about a primary care approach. So I will first talk about some of the relevance of this topic, especially in primary care setting, descriptive epidemiology around infertility and its lifetime evolution in couples, talk about underlying causes in a brief overview, and then talk about a primary care approach. So overall, about 10 to 15% of couples report that they are unable to have the number of children that they would like to have. And that's across a number of different countries. It comes up, developed countries comes up fairly similar. In a population-based survey of women in the UK, they surveyed women who were mostly past their reproductive years. They were age 40 to 55. And so they were asking them to look back on their lifetime. And 16% had ever consulted a doctor for some problems conceiving. Of those, half of that number, 8%, had had fertility treatment. And of those, about 4% had never had a live birth. So it kind of about half. Half ever saw a doctor, half ever got treated, and half of those never had a live birth. You also, if you look at the math, you'll notice that a number had a live birth that never got treated. We'll come back to that. It's important to recognize that fertility problems are related to other problems. Among them include pregnancy loss, so miscarriage, perinatal outcomes. Women that have infertility have a higher risk of some perinatal outcomes like preterm birth, other chronic conditions and health risks in women and men, and psychological and relationship stress. So overall, in primary care especially, we're trying to look at the whole person and the whole family, the whole situation. Reproductive and prenatal health are a part of overall health. And some people, some researchers consider fertility issues to be kind of a canary in the coal mine for how we're doing with our overall health in a population. It's important to recognize that fertility, or a more technical term for it, fecundity, is a spectrum. It's a matter of probability and time. So the time cutoffs we use to identify a fertility problem, which is usually we say 1 year of trying, this is by convention. It's not a biological threshold. It does take 2 for natural conception. And usually this doesn't show up until the couples start saying, oh, we're trying to get pregnant and it's not working. So to illustrate this is a paper a few years ago where they looked at time to pregnancy in couples out of Europe, a number of European countries. And so if they looked at the number of cycles they were trying to get pregnant, this would be about the year mark here. And they looked at it by age group. So the younger age group, 1926, had a shorter time to pregnancy, and the 35-39, somewhat longer time to pregnancy. But you get to this year mark, and then if you go out another year, the estimated percentage of infertile couples, meaning 1 year of trying, and would be able to conceive after an additional 12 cycles of trying, varied around 50%, depending on age. So it's important to recognize that's not to say that the only thing to do is just try longer. It's just to recognize that any cutoff is not a biological cutoff necessarily. It's looking at probabilities. Initially, there's a rapid proportion getting pregnant, and then it tapers off over with a much shallower slope over time, but still there's a continued spontaneous conception. And this raises the question of what's trying. The general definition for this is regular intercourse without contraception. What does that mean? Once a week, twice a week, more often? Does it mean tracking the cycle, which women are doing much more these days? Are they doing it in an effective way? Are they identifying the fertile window? It's pretty common for couples to say, we haven't always been using contraception. We haven't started trying, or we started trying, last month. But if you ask them, when did you stop using birth control? Well, we really haven't been consistent for a few months. So this is just again to illustrate that the time to pregnancy is not an exact thing. It's a probabilities, and understanding in each individual couple history is important to dig into that a little bit. Primary infertility, of course, is never having had a prior pregnancy or birth. People define it both ways, pregnancy or birth. And secondary infertility is as having had a prior pregnancy or birth, but then not being able to get pregnant in the time that people would want to. So infertility is a syndrome. It's not one disease. There's not like one disease called infertility. Although people can call it a disease, it's really a syndrome because there's multiple underlying conditions, multiple underlying diseases that can cause infertility. In one of our studies of 370 couples in our review, we found a mean of 5.5 related diagnoses per couple. That's in a study where we were really looking for all the underlying causes. That's not necessarily always the case. And about half of couples had a male and have a male component. And again, returning to this question of who gets seen, of couples that ever have trouble getting pregnant, only half of them ever go to a doctor for advice or any kind of treatment. About half of those get any kind of treatment. And then there's a lot of evaluation and treatment, and variation in the evaluation and treatment they might get. So in primary care, we start with lifestyle, of course. Obviously, don't smoke or stop smoking, moderation in alcohol and caffeine and preferably not using recreational drugs. Exercise and maintaining good metabolic health are just starting points, but they are critical starting points for both, especially women, but also men in terms of fertility. Jumping back to the comparison of what's going on in the general population, we want to look at that as opposed to just what happens in specialty clinics. This is a study we did a few years ago where we looked at a clinic-based sample of subspecialty clinic of women that came in for infertility, and then we recruited a population-based sample based on the Utah population database of women who had experienced primary infertility. These were all primary infertility. And overall, the women who came to the subspecialty clinic, this is not primary care, subspecialty clinic, were much more likely to have gotten some medical treatment, and about half of them ended up having IVF almost, and 55% ended up with a subsequent live birth. Where in a population-based sample, 59% had ever had medical treatment of any sort, somewhat over half. 14% ever got IVF, and just a few percentage less, 52% ever had a subsequent live birth. So there's a whole, what happens in an infertility clinic, a subspecialty clinic, is not representative of what happens in the whole population. It's an important part of the spectrum, but it's not the whole spectrum. Well, I just said that there's multiple underlying conditions. What are some of the main underlying conditions? Well, women, PCOS is a huge common condition, and one that in primary care should be very familiar with because it has other implications besides fertility. And of course, the diagnostic criteria are longer cycles or sporadic or oligoovulation or anovulation, along with hyperandrogenism, either clinically or biochemically or both. And then the multiple small cysts on the ovaries, which patients often don't understand. They think of these huge cysts. They're really physiologic cysts. There's just more. The problem is there's too many of them. And the ovaries are therefore enlarged usually. Other parts of it that are not part of the diagnostic criteria, but are definitely part of the pathophysiology, are insulin resistance. And in fact, there's literature suggesting that we really should rename PCOS because it's named after the least important part of the condition. The cysts are the least important aspect of it. It really should be called ovarian metabolic syndrome. And it's not always associated with obesity, but women who have it also have a higher risk of obesity and of course, gestational diabetes and diabetes. Other common underlying conditions for infertility in women are other ovulatory disorders, obesity that's not PCOS related, underweight, such as eating disorders or other reasons for being underweight, hyper-performing athletes sometimes. Thyroid disease is relatively common. Endometriosis is very common. Now, this is a little bit controversial about exactly how common, but it's very, I would say it's at least in the 25, I'd say 50% plus range of women with infertility. And we can get back to that if you're interested in why that gets somewhat controversial about the exact prevalence. Prior pelvic infections, of course, tobacco and other substances, also fairly common. And this is not an exhaustive list of possibilities. These are common lists. So male common underlying conditions would be congenital, relatively common. I wouldn't say these are extremely common. Undistended testes, even if they were treated. Microdeletions in the Y chromosome. Varicocele, also, this is another condition that's common, but somewhat controversial about how related it is to subfertility in men. But it definitely has a fairly common occurrence in relationship. Obesity, tobacco, and then one that really should always be asked about is anabolic steroids, epidandrogenic, but anabolic is the term that would be more associated. They're androgenic too, that are used for bodybuilding and that sort of thing. Those are like birth control pills in men. Will shut off sperm production. One thing that's really important in men to know is that sperm concentrations are like blood pressures. You measure one blood pressure, you have some idea about whether somebody has high blood pressure or not, but you don't really know for sure unless you've done a number of them over time. Semen analyses are harder to do than blood pressures, but they do vary. You just need to keep that in mind. These are 45 men who had semen analyses done repeatedly every month over 9 months, and variation in counts that they had. Another thing to keep in mind about semen parameters in men is that they're not that great in terms of predicting fertility or fecundability, but they're the best we have currently. So that's what we use. So these are, this is out of some data out of a large Danish cohort study where they looked at the ability of men to cause a pregnancy, their fecundability, their fertility, if you will, related to sperm parameters. And so you can see that it's relative. Let's talk about sperm concentration here. This is 250 million per cc down to 50 million per cc. And you can see that over that spectrum, there's not a lot of variation in terms of this is their per cycle probability of pregnancy and percentage. It's not that different until you get to really low, and then it drops off. So the low end of the sperm semen analysis parameters, that's where you're getting down under the current cutoffs. They'll say 15 million. That's where you really do see a difference. But in this upper end, there's a whole spectrum with not a lot of difference. The same thing with semen volume, motility, has to get to this percent non-motile, has to get down to like 10, 20% before of motility, 80% non-motile, and same thing with morphology. So that's just something to keep in mind with semen. There's a lot of gray area for semen parameters. So there's I think a very important role for fertility awareness, by which I mean not just general knowledge of fertility, but knowledge of the menstrual cycle and the fertility cycle for women and couples dealing with fertility. The menstrual cycle, of course, is for hundreds or thousands of years, and who knows how long, has been timed according to the menstrual bleeding, because that's the visible part of it. But the other part of it that's even more important is ovulation. And so the question we'll come to in a minute is, can women identify that? And sneak preview, the answer is yes, with some effort. The fertile window are the days of the cycle when intercourse is likely to result in pregnancy, and that's obviously of relevance for couples trying to conceive. I think this is just a brief reminder of the ovarian cycle with the development of the antral and the pre-antral, then the antral follicle, then the release of the egg, ovulation, and then the corpus luteum afterwards, with and the corresponding hormones of estrogen prior to ovulation rising, LH surge, and then progesterone after ovulation. So these are, there's one thing that's not correct on this slide, or at least misleading, and that is putting day 14 here. I'll come back to that. So menstrual cycle length, this is a group over 560 women who are not taking any hormonal medications. And we had just looking at what a normal distribution of menstrual cycle length is. The typical stereotypical cycle of 28 or 29 days is in this, 27, 28, 29 is in this. This is about half of cycles, or a third actually of those three. But there's a lot of variation, sort of a somewhat normal curve with a right skew distribution for cycle length. So given that cycle length can vary, on what day of the ovulation of the cycle does ovulation occur? I give just a minute for anybody to type an answer into the chat here. On usually, with the term usually here. $15. 13 to 15. Well, those are pretty good answers. This is a range. The day of ovulation in this same study, slightly different number of women for reasons because there were some conception cycles. We couldn't do cycle lengths and conception cycles. The mode was about day 15 actually, but you have a whole spectrum here. And if you looked at the number that actually ovulate on day 14, about 11%. So there's a whole, if you wanted to put a range on it, that would capture about 95% of the cycles. You go from about day 11 to about day 22 or so. There's a normal healthy variation in the day of ovulation. So after ovulation, what's the typical duration of the luteal or post-ovulatory phase? And Lisa Roberts just answered 14 days before the next cycle. So her answer to that would be 14 days. So that turns out that's kind of a spectrum too. Luteal length here again varies. The mode would probably be about 12 days. It can, and if you wanted to capture 95%, you go from about 9 days to about 16 days. Now this is across a group of women. Within an individual woman, there will be less variability. So one woman might have a typical luteal phase of 15 or 16 days, whereas another woman might have a typical luteal phase of 9 or 10 days. So this is, for couples trying to conceive, this is an important question. How many days during the menstrual cycle can a woman, or it usually takes 2, get pregnant? You type again, type in the chat. Six days. 6 days is pretty commonly stated, and that's based on several studies, especially these two, where the probability of clinical pregnancy on the day 0 is the day of ovulation, estimated day of ovulation, in one case hormonally, in the other case based on temperature. And these populations differ, and this is a probability of clinical pregnancy from intercourse on that day. So this one got up to 45%, this one about 28%. The difference in these populations, this had women that had all previously had children. This one had more nulliparous women. But the overall pattern is that the highest probability of conception is from intercourse on the 2 days prior to ovulation, and somewhat the day of ovulation, and not afterwards. And then you can go, these are women of normal fertility, couples of normal fertility. If you look at subfertility, you can imagine that this would be shifted downwards and maybe narrowed as well. So this time frame of, I'll go back to when the probability of conception is higher, is also the time frame when estrogen is peaking. And another biomarker with that, type E cervical mucus. I just want to briefly review that the type E estrogenic mucus, which is colloquially online called egg white mucus, meaning raw egg white. I don't particularly like that term because it doesn't always look exactly like raw egg white, but that's a term that's used a lot on various websites. Under the microscope, the type E mucus has the channels for the sperm survival and transport. It's really important to recognize that this fertile window, when there's estrogen high and the mucus is present for the sperm, it can happen early, mid, and late cycle. And these are just 3 different cycles with a schematic showing when the mucus and the fertile window is, as charted by the woman based on her cervical mucus. This is a 25-day cycle. That's in normal range of cycle length, 29-day cycle and a 35-day cycle. And in this cycle, the entire fertile window is come and gone by day 14. In this cycle, the fertile window does center around day 14, kind of the stereotypical. And in this cycle, the fertile window hasn't even started on day 14. Right? So the estimated day of ovulation here is day 10, here's day 14, here's day 22, all normal. And it's just to recognize that that there's more variability in women and their cycles than often women recognize and sometimes clinicians recognize. So this begs the question, how can women identify her ovulation and fertile days? Well, so this is back to the fertility awareness I was talking about. Women and couples can learn to determine their fertile window by observing their biomarkers. What are those? These are some of the, I need to update this slide with some of the apps. These are some of the, taking charge of your fertility has been a popular one. So before ovulation, the mucus increases. That's seen as a vaginal discharge that can look like egg white, or it can have some other characteristics. There's a rise in urinary estrogen, and there are devices on the market that will let you test that. The Clear Blue is the main one that's out there. The LH Surge, there are a lot of those are the ovulation predictor kits that are out there. After ovulation, the mucus decreases, the temperature rises, that's the basic body temperature sign. Progesterone metabolites in the urine, there's now another urine test on the market over the counter to measure progesterone in the urine. So these are put into a number of different systems to identify the fertile window. I've just listed some of the main ones out here that I think have, they have data and credibility, published studies behind them. One thing I want to say here, and I'll slide on it, but there are really literally well over 100, maybe hundreds of apps out there for cycle tracking. And a lot of them will have to put in the day of menstruation, the day of each period starts, and based on that, we'll calculate a fertile window. And most of theirs are really garbage. The algorithms they use are really not only poor, but sometimes actually very wrong. If you want an algorithm based on calendar days that really does do a reasonable job identifying the fertile window, I would, if someone has very regular cycles, they can use the standard days algorithm. It does a very wide fertile window. Or there's a dynamic optimal timing, and that's been recently incorporated in the Clue app. And that's a Bayesian algorithm that bases on each cycle length of a woman, recalculates a fertile window. So if somebody wants to just use their day of menstruation only and not look at any of the other fertility signals, I would recommend the DOT algorithm, which there was a DOT app, it might still be out there, but it's been bought up and it's being used by the Clue app now. Other things are the urine tests, the urine LH tests, but they do only give you a limited window. Remember, it's the 2 days prior to ovulation that are the highest probability of pregnancy. And the LH, gives you about one of those days. The peak day method is a simplified method we developed and validated for tracking cervical fluid and optional temperature, and you can find it by Googling peak day Utah. The Billings method or the Creighton method have fertility educators that meet with the women to teach them the method. That can sometimes be, often, I would say in many cases, very helpful for women to have a teacher meet with them and take more time than you can do in an office visit. Marquette method has some online approaches, online teaching, and it uses the Clear Blue monitor for estrogen metabolites and LH. And then there's the basal body temperature. It can be helpful retrospectively. It doesn't tell you prospectively when the fertile days are, but then it can be used to estimate for the next cycle. And there's an app out there for that. It's called Natural Cycles. There are other apps too, but that's one that got some FDA approval. And then Symptothermal combines some of these symptoms. One of the apps, and I don't have a financial interest in any of these apps, is Kandara that does that. Taking Charge of Your Fertility. Couple to Couple League is another organization that teaches a combination of temperature and mucus tracking. Well, what does this actually do if couples use them? These are couples, again, this is not yet subfertile couples trying to conceive, or women, I should say. The study was women. They had to be in a heterosexual partnership to be in the study. We looked at women who are, first of all, so this is a large online internet-based preconception cohort study that I was been part of. It's based out of Boston University. You can see the number of pregnancies across these different categories of what women were doing when they got pregnant, number of cycles. And then a fecundability ratio, a higher number is shorter time to pregnancy. So a higher number is quicker, being pregnant quicker. And the one that got the shortest or the highest fecundability ratio is charting days, tracking cervical fluid, and urine LH. But in fact, using almost any of these, the ones with the small numbers, I think, have sort of unstable estimates, but any of these with these larger numbers, basically any combination of tracking the fertile window was better than not tracking the fertile window. So back to what about the infertile couple? Let's just briefly talk about evaluating someone who's been trying and the standard would be 1 year, but I think a couple that comes in is concerned. There's some things that you can do right away. Refer them for some of the fertility awareness women should be, and couples should be able to look at it immediately and not have to say, oh, just go try for 6 months or 9 months before we do anything. So initial history, I'm not going to walk through these one by one, but there's just focusing, it's often said that 80 and 90% of medicine or clinical care is history, and this is true here as well. So these are all things that would relate to what's happening with the reproductive potential on both the woman and the man. And I want to emphasize that if you're really taking care of this situation, you need to think about both partners. Again, there's a male factor component about half the time. What about the physical exam? On the women, these are the focus things. You would look for signs of any virilization or androgenic influence. So acne, hirsutism, maybe acanthosis nigricans. That's more of an insulin thing than an androgen thing. The body mass index, of course, their overall adiposity. More history, but maybe exam galactorrhea. Thyroid exam and pelvic exam for any anatomic issues or pain. And the male side, there's the urologic exam, especially for varicocele, possibly hypospadias. On the initial laboratory, women, you need to know, are they ovulating? How is their cycle? And this is more than just, do you have a cycle every 29 to 31 days or 20, whatever. This is where I think having the woman learn or track her cycle in one of these ways that she's interested or willing to do so can be extremely valuable. Nowadays, I find that women come in with a history of cycle lengths, at least, on an app. And that's a good starting point. And then I ask them to do one of these other methods that will also help them identify ovulation in addition to just cycle lengths. And not just that their app told them that they ovulated on a day based on, who knows what. If the app's doing it just based on the cycle length, that's usually not accurate. The checking to make sure the tubes are open, that could be a hysterosalpingogram standard ways. It's also, I think, reasonable in somebody with a low risk history to just do a chlamydia antibody. If they never had chlamydia, if they don't have any antibody evidence of ever having had chlamydia, that's the most likely cause of having a tubal obstruction. So that can be a low cost alternative. Consider thyroid, pretty common enough. Prolactin, maybe, that's arguable. But especially I think if somebody's a secondary infertility and they have a history of breastfeeding, I'm a little more inclined to check and make sure that's back to normal. And then thinking about PCOS, PCOS could be a whole talk in of itself. But I'm assuming that you have some familiarity with it, and it's a big factor. Some people or other metabolic abnormalities that may not hit the PCOS, all the criteria, but are on that spectrum. On the male side, semen analysis, the history we've talked about, and then also looking for metabolic abnormalities. It has been shown that fertility is related to BMI, and this would also, as well as some relation of fertility to lipid abnormalities in men. So I mentioned earlier a study where we looked at women who were recruited from a subspecialty fertility clinic versus the women who were recruited from the population. When we combined them all together and looked at their time, these are women with primary infertility. And so it took they are all primary infertility, so they're all 0 at 12 months. They had to meet that definition. So by the second year, you're at about 25% or so. And by the third year, you're up to about 40% or so that have had a pregnancy. The ones that saw a generalist provider first, that could have been a family doc, a midwife, or a general OB-GYN, their curve is not statistically different, and they kind of jump around and cross each other from those who saw the fertility subspecialist right away. And the likelihood of, if they saw a generalist provider first, they're just as likely to have a live birth, but the likelihood of getting IVF was half. And to me, that's a good outcome when you can do something for less invasive, less costly procedure. There is a role for a generalist initial evaluation and initial treatment. And the main concept here is that restoring underlying health will often, usually I would even say, improve healthy reproduction. Doesn't guarantee that they're going to get pregnant, but their overall problem that they're not getting pregnant in the first place is related to underlying health conditions. And if that is metabolic, that includes metabolic conditions or PCOS or other issues that can be treated, then lifestyle habits, smoking. So again, this connection between overall health and reproductive and prenatal health. So certainly on the male side, there's lifestyle counseling, of course, healthy habits. If there's varicocele, I do think at least having a urology consultation about it is worthwhile. Treating underlying conditions, by that I mean metabolic abnormalities, insulin resistance, prediabetes. And secondarily, that will also treat weight. I'm a believer in making the metabolic condition the primary target of treatment and making weight the secondary thing. Women, the same thing, learning the cycle in the fertile window, treating underlying conditions again, metabolic issues. And then if endometriosis shows up, and that can be a whole talk in of itself, the symptoms that make you, and the exam findings that make you think of that, then I do think a surgical referral is warranted. That's a whole topic in of itself, or at least a discussion about that. So there's a concept in treatment that I use called optimized cycles. This is just not, oh, you've tried for 12 cycles, or we gave you Clomid for 2 cycles, or whatever. It's actually an optimized cycle. An optimized cycle is where we have evidence of ovulation. We have evidence that there was at least one active intercourse on the highly fertile days. Those are the 1 or 2 days prior to the estimated day of ovulation. The days are the days of best quality mucus. That the luteal post-ovulatory phase was at least 11 days long, giving time for implantation to occur. And this can be supported and lengthened with human progesterone. That's human identical progesterone. Brand name for that is Prometrium, not Provera, not a synthetic progestin. Checking progesterone and estradiol levels 7 days after ovulation to see what kind of hormone support the luteal phase has is something else I do routinely. And there's no abnormal bleeding and spotting. So like you're not getting like premenstrual spotting of 2 or 3 days. This is more nebulous, but critical to look at the psychosocial stress side of it. And then if there's no pregnancy in 6 optimized cycles or so, that's a good time to say, well, we've done a good run of this. Let's get you in for more detailed evaluation. And somewhere in here, looking at the chlamydia antibody and or the HSG, it's for each couple, based on their risk factors, maybe what they have access to. Some cases, unfortunately, it'd be what they can afford, but also how aggressive they want to be. There'd be different thresholds for when you're referring or doing studies. Like the semen test, I think ought to be done earlier in many cases. Sometimes that's put off too long. You really want to know if there's a serious, very low semen analysis, sperm count. In general, if we have restored mom, dad, we have healthier babies. There's just a couple of clinic-based studies we did with this approach showing that the low birth weight and prematurity rates were well under 5%. The current statistics across the country for IVF at 2018 as of SART are 9% low birth weight and 15% prematurity. So understanding the fertile window, to wrap up here and then go to questions, understanding the fertile window is a fundamental part of women's health and reproductive health. The fertile window is about 9 days on it. When you identify it by mucus or temperature or hormones, you're going to have about a 9-day fertile window as opposed to 6 days, because we don't have this very precise identification in the study by ultrasound in the study. Primary care should perform the first steps of fertility evaluation and continue to follow the couple, especially for underlying health conditions. And you're often more, you would be just as good or better at treating underlying prediabetes or metabolic abnormalities or lifestyle issues as the subspecialist would be. So happy to be contacted down the road about anything that may come, question to come out of this. Now I'm looking forward to having a few questions here. Differences in approach for primary versus secondary infertility. Well, that is a good question. What does, usually with secondary infertility, you can somewhat rule some things out. For example, unless it's much less likely that there's a tubal blockage. There could still be a male factor, but it's a little bit less pressing to think there's a male factor. So it steers your evaluation a little bit. In general, women with couples with secondary infertility have an overall better prognosis. So that doesn't mean you're not doing anything, but it means you're reassuring them that some of the more simple lifestyle and understanding the cycle steps are more likely to be enough for them, and that there's less likely they need going to end up needing invasive treatment. So that would be the short answer for that. And I think, Caitlin, you had some initial questions that were sent before the session.
Yeah, indeed. Let me just pull those up right now. And actually, I have a question for you, Joe. In the meantime, I noticed that AMH test wasn't included in the initial recommended labs. Would you say that has a more limited ability to predict fertility?
Yeah, that's a really good question. I actually use AMH a fair amount, but I use it for a different reason. So AMH is a predictor of response to ovarian hyperstimulation and IVF in IVF settings, and it's used to, especially in women who are, say, in the older part of the reproductive age range. And so it's used a lot to predict response to IVF or to the hyperstimulation protocol site of IVF. It has been shown now in a couple of good cohort studies to not predict spontaneous conception or natural conception in women who are older. Now, I wouldn't say those studies are like the definitive proof that it has no prediction at all. But women with, it's also been my experience that women with very low AMH levels can still get pregnant through these more restorative approaches. So I don't think it should be used to say, oh, your AMH is really low. You should give up and go do IVF. Actually, what they'll do, say on the IVF side, is, okay, donor egg, So the thing that AMH is probably two things that I think I use it for. One is to actually look for the timing of menopause. It has been shown to help do that. And the other is, it's actually a very good marker, in my opinion, for PCOS. It's elevated, but it's not part of the diagnostic criteria for PCOS yet, but I find if there's some kind of, borderline case, is this just someone that is having some hyperandrogenism because they're overweight, or did their, which came first? Did the PCOS kind of more drive what's going on? AMH can make that distinction, I think. And there's some data suggesting that, but all right, that may be more than we wanted about AMH.
That's great. That's great. So some of the questions that we had come in prior to the webinar, what's a good approach to evaluating male factors of infertility? This provider typically evaluates for factors that can decrease sperm count and get a semen analysis, but is there anything else to do?
Yeah, that's what I said earlier, that we do semen analysis because, first of all, you don't want to miss somebody who has a very low sperm count and be doing all this stuff for his partner and not recognizing that we should be working on him. But most of the time, the semen analysis is going to be either, about half the time it'll be fairly normal, and about 45% of the time it'll be in this gray range, this kind of indeterminate range. And it's kind of frustrating because the semen analyses are not that great of a test, but it's the test that we have. Having said that, I do think there are some things you can look at, especially for a couple that's been trying for a while. So the Y chromosome microdeletion, the possibly DNA fragmentation tests. I do think there's some evidence those have some value, the DNA fragmentation in sperm. So those tests are available and you can order them. And I don't think they're first line, but if you have a couple that's farther down the road and, the semen analysis is kind of like in that gray range. And then the question is, what do you do about those? Well, they're both of the oxidative damage or the DNA damage is related to oxidative stress. So then in theory, supplements, antioxidant supplements, the problem is studies on those so far have not. A couple of major studies recently have shown those really didn't work in randomized trials. So then you're back to, well, is he smoking? Is he eating an oxidative type diet, or is he eating a healthy Mediterranean type, and what are his lipids, what are his CRP, what are his metabolic status, what is fasting insulin, those kinds of things, metabolic status. And then you're back to diet, and like maybe that's what you should have done in the first place. So yeah, that's where we're at with male fertility, I would say.
Great. And for providers who might have a background in microscopy and post-vasectomy semen analysis, are there any resources on learning to do that there, without, ostensibly besides sending it out to a lab for analysis?
That's a really good question. I think you can do it. I don't do semen counts myself, but I do think they can be done. If you have a way to do that more conveniently and maybe more cheaply for the couple, I would just say that if it's in a totally normal range, you're good. If you're in a kind of borderline range when you do it, then I think maybe you want to send them for a lab that specializes in it to get the exact little better picture. Now, this would be the same thing I would say about home semen tests. There's I don't know how many of them are actually on the market now, 3 or 4. And couples ask me about those. What about those? We can just do that at home. I say, yeah, if it's totally normal, I'm good with that. If it's in a gray area at all, then you need a follow-up better test. So.
Great. Yeah, we did have a couple more questions. Other than weight loss and metformin, are there any other treatment approaches to help women with irregular periods and obesity with normal ovaries and without hirsutism and normal hormone levels for cases where it seems like PCOS but doesn't quite meet the criteria?
Yeah, this is a good question. And I think PCOS really is a spectrum, actually. And there's, so in terms of, so I routinely measure insulin sensitivity because I find that it's so often abnormal, and it's weigh in normal weight women as well as overweight women. Now, I guess if there are things that pointing clearly in a different direction, and there's no overweight and there's no, but it's pretty routine for me to measure fasting insulin, and maybe an A1C, which, there's those intermediate ranges of A1C, like 5.7 is abnormal. Well, if a woman has 5.6, is everything totally fine? Maybe not. So then if obviously you start with the diet and exercise there, the low carb diet, trying to help people, not women and men, both understand that, our American diet is so carb heavy, and, if they can not necessarily calorie count, but track carbs, that's one, or there's a couple approaches for that, but, the low carb side of things. And then in addition to metformin, there's inositol. That's a B vitamin related supplement that does have insulin sensitizing effects. It does reduce insulin sensitivity. It has been shown to improve those parameters. There's berberine as an herbal supplement, also a good randomized trial showing that for berberine. So there's a number of things, and then there's other medicines, pioglitazone, there's both on the natural side, the lifestyle side, the medication side, there's a lot of potential ways to get at the insulin sensitivity. And that's just a key part of metabolic health and that affects fertility for sure.
Great. And then just a few additional follow-up questions. Can you use progesterone to induce menstruation and then clomiphene to help with ovarian stimulation? Is it appropriate for primary care doctors to use clomiphene routinely in infertility patients?
Yeah, that's a good question. Let's start with the progesterone. That's easy. Yes, progesterone is a kind of a way to have, often a way to normalize cycles without suppressing ovulation. So it's kind of like someone's having somewhat irregular cycles, somewhat longer cycles, often giving them that progesterone 10 days will get them into a normal cycle in a way that does not suppress ovulation. So I give progesterone either 3 days after their ovulation marker. That can be the mucus peak or the temperature, last low temperature, or the urine surge, LH surge. 3 days after ovulation, start progesterone, or day 17 of the cycle, whichever comes first. And some women, if they're not tracking, and start on day 17, not day 14. That's too early. There's enough ovulation that happens before then. But you just start the progesterone and give it for 10 days. It can be oral or vaginal. Again, I much prefer prometrium or natural generic prometrium to the synthetic progestin. And that, for many women, that will just have a little bit of a metabolic abnormality, or just not, that'll get them into a normal cycle, and they will sometimes get to ovulate, which is that, along with some good diet, some good activity, dropping a little bit of weight. So that one's easy. Clomiphene. So the short answer to that is I do think it can be appropriate to give clomiphene. I start at lower doses than standard. So a standard dose for me starting dose would be 25 to 50 milligrams for 3 days. If you're getting into the over 50 milligram dose for 5 days, then I think you need to be tracking with ultrasound. That's my opinion. If you're looking at the lower doses of clomiphene and you're tracking it with like temperature or mucus or ovulation kits, I think that's okay. Now, having said that, I would also say that there are pretty good data that women with PCOS respond better to letrozole. And so get familiar with letrozole, use that in somewhat lower doses for a few cycles, that's fine. The optimized cycles I was talking about. If you start climbing the doses very much, then I really do think you need ultrasound. And the reason I think that is because you're raising your risk of multiple gestation. And, a lot of women will say, that's fine, I want twins, but I still say to them, I understand that and that's great. And if it happens, we'll be happy. But at the same time, it's riskier for you, it's riskier for the babies, a lot riskier, even though the risks, with good medical care, twins will be fine. Most of the time, it's still a lot riskier. So whenever you're starting to go very long on the ovulation medicines or increasing the dose, then I think you need to be doing ultrasound to track it.
Great, thank you. I'm going to just share my screen again. Thank you for this excellent talk. I know we are just about at time, just a couple more minutes. For those interested in claiming 1 CME credit for this webinar, we will email you the code and instructions for claiming your credit once you've completed your post-webinar survey. If you've set up a CME profile with the U before, the process is very simple. Just call the phone number to enter your event code. And if you haven't set up the CME profile with the U before, you'll be asked to complete a brief form before claiming your credit. The one thing I do want to emphasize is that the CME credit must be claimed before midnight tonight, at which point it will turn into a pumpkin and will not be available. We will be sending an instruction guide for which should answer most of your questions, but of course, don't hesitate to email us if you need any assistance. And finally, we do ask that you complete our post-webinar survey. Just like the pre-survey, there are a few different ways to get there. Type the URL into your browser, click on the link in the chat box, or hover your smartphone camera over the QR code. And the survey will ask if the webinar has taken place yet. Make sure to answer yes, so that the appropriate questions do appear. It has been an absolute pleasure hosting you today, and we hope that you will join us next month for the last of our webinars in this series. And next month will feature our very own Dr. David Turok, and he will be joined by Dr. Andrew Garrison to present on vasectomy. Thank you all, and take good care of yourselves. And with that, I will leave you to take the survey.